we're going to get through everything today. So we're going to do blocks, we're going to do the ventricular dysrhythmias, and then we're going to go back and pick up on interventions. Okay? So that's my goal today, and I'm going to meet it. But you know, I always like to do a check-in. So let's do a check-in. Okay?
I want the first question, please.
Oh, James, I'm glad you volunteered. Okay? So, here's my question for you. What is the dominant pacemaker of the heart?
I want to phone a friend, please.
You can't phone a friend.
Wait, yes,
Talk
please.
about me. Okay, phone your friend. You know that.
Kim.
Dominant pacemaker of the heart. Okay. So, Kim, where does it go from the SA?
To the AV.
And then to the...
From the SA node to the AV node to the bundle of his.
Your bundle branch system. Yes.
And then down to the, it's starting with P.
Purkinje fibers.
And
Yep.
it goes up.
Okay, very good. So, knowing that, Kim, will you please select someone?
Gina.
Okay, Gina, this is an easy one. Every little small box on your EKG represents what in time? Okay, no, every small little box represents every square. You can phone a friend. It's fine. Okay, every small box is
Is it 0.04?
very good. Yes, 0.04 seconds.
Kim know her stuff.
So when we read on 6-second strips. Okay, so that's what we have to realize. So now, Kim, select someone.
J.
Okay.
My phone off.
Okay, so here's my question. If I want to know what's going on in the atria, what part of the cardiac cycle do I look at?
Wait. You saying?
I want to know what's going on in the atria. So when I look at my cardiac cycle, or when I look at my EKG, what part's telling me?
So you're looking
that?
at the P wave.
Very good. If I want to know what's going on in my ventricles,
QRS.
okay. If I want to know how long it takes an impulse to get from my atria to my ventricles, what part do I look at?
The PR interval.
PR interval. Very good. Hey, why am I concerned about changes in T waves?
Why are you?
Why would I be concerned? If I look on an EKG and I see T wave changes, why am I kind of concerned by that?
Well, okay. Ischemia.
Very good. Ischemia. Yeah. Oh, well, what happens if I see ST elevation or depression or changes in my ST? What am I worried about?
Well, that's that's talking about troponins. So you're looking at dysrhythmias with that.
Your ST segment.
Okay. I don't know that.
Phone somebody. It's okay. You got a whole nother week.
Kim.
Yeah.
Can I phone someone else?
You phone someone else.
Quan.
Okay, Kwam. Why do I worry if I see, or how about, what does it mean if I see ST changes potentially on an EKG?
Potassium.
Good guess.
I feel like my guess might be wrong. Start with the S. Josh. I mean, I don't.
Why do I worry about
It's
ST?
ischemia?
Yeah, ischemia, guys, remember? We worry about, remember we have STEMIs and non-STEMIs,
Oh.
okay? So yeah, if you're looking at EKG and you have ST changes or you have T-wave changes, you think, ooh, I got some ischemia, I got some damage or something here. Definitely. Now, Josh, tell me what you know about sinus brady. What's the problem?
It's too flat.
Okay, what's our normal?
Less than 60. Or like the regular heart rate?
Uh-huh, a normal.
60 to 100.
So our normal is 60 to 100. So sinus brady is less than that 60. If they're asymptomatic, what do I do for it? Nothing, right? I mean, check their blood pressure, make sure their blood pressure is adequate.
It can be very active.
Yeah.
Yeah, because it could be athletics.
Absolutely. Okay. So let's say they're symptomatic. What symptoms would you anticipate seeing?
Decreased cardiac.
What'd you say?
Decreased cardiac.
Yeah, your signs and symptoms of decreased cardiac output. Hey, what are some of those?
Like weakness, fatigue.
Very good. Weakness, fatigue. Josh, what's my overall goal?
To increase the heart rate.
How am I gonna do that?
Atropine.
Atropine. It's gonna increase it. We'll give it IV. Okay? So Josh, will you please select someone? Christina. So let's go to the other end of the spectrum.
Okay.
And let's talk about sinus attack. What's wrong with sinus attack?
Too fast, greater than 100.
Yeah, it's just too fast. Why is that a problem?
Your heart's beating too fast and your body can't keep up with it? Or it's just perfusing way too much? So you're putting more strain on your heart?
Yeah, so remember when we talk about sinus attack, initially, yay, sinus attack's good. It increases cardiac output. It's going to increase the blood pressure. But remember, over time, ooh, it's bad. Because it's going so fast that the ventricles don't have time to feel adequately. So when you have a decrease in your filling time, what that means is it's not going to perfuse out like it should because you just don't have enough. And so when that happens, what you're going to see is you're going to see a decrease in cardiac output. You're going to see a decrease in that blood pressure. Okay? So we got to do something. Now, can I say, can I give you a definite number of hours a person can be in sinus attack before you got to do something? Why can't I do that? Why can't I say that?
Because you don't know how long you've been in.
And what else? And what else? And you can phone a friend. It's okay.
Michelle?
Their overall picture of health.
Yeah, remember we're all a little different, guys. So your ability and my ability to sustain that is going to be a little different. Okay? But just realize that while initially it's good, over time it's poor. Okay? Because again, it's going to lead to decreased cardiac output, decreased blood pressure, and ultimately lead to cardiac failure. Okay? So we don't like to keep people in sinus attack for prolonged periods of time. But Michelle, is sinus attack sometimes normal?
Sure.
Give me some examples.
Infection,
Absolutely.
anxiety,
Yeah.
hemorrhage.
Okay. Absolutely. What are some other things that can cause sinus attack?
Medications,
What kind?
stimulants, illegal drugs.
Definitely. Yeah. So like your diet pills, thyroid medications can cause it. A little cocaine can cause it. Just a little, not too much. Okay. What are some other things that could cause sinus attack? Do you think? Check-offs.
Yeah.
Exercise.
Exercise. Oh, but it's okay in exercise, right? Why? Why is sinus attack okay sometimes and it's not okay other times?
You need that,
Because
you need that perfusion.
Yeah, it's temporary, like exactly what you said. As soon as I'm done exercising, I sit down, what's going to happen to my heart rate? It's going to go back down, okay? So in those instances, like what you said, fever, anxiety, like we get it back down, and you know what? That sinus attack's going to go down, okay? So caffeine is another one, guys. I mean, we all like our caffeine, but too much of it is not a good thing, okay? And then when you look at interventions, what are some interventions you would think of?
Bed rest.
Yeah.
Don't do caffeine or cocaine.
Okay, don't do a lot. Moderation's the key for everything. Just a little bit of caffeine. Okay. Hey. Hey, what you do in your own time is your own business. So no ask, no tell policy here. But yeah. So we try and figure out what the cause is. Okay, so if we can figure out the cause and we can eliminate it, let's do that. If it's because of medications, maybe, like for example, thyroid medications, we maybe need to adjust it a little bit, okay? But guys, some people, that's just their normal. They just have a higher heart rate than most people. And if that happens, then we can anticipate a beta blocker there. Just a low dose, daily beta blocker, okay? Because we know that ultimately it's not good for your heart rate to maintain high like that. It's going to mess up your perfusion. So we'll get you on like a low dose, like a 12.5 beta blocker, okay? And just remember, we got to educate them because you will feel kind of crappy when you start those beta blockers. And just realize that you become used to those signs and symptoms and it doesn't bother you as bad, okay? So those are some things that we do for sinus attack. Now, Michelle, will you please select someone who can enlighten us about, let's do AFib.
Nicole.
Oh, but you know this. No. You do. Okay. So when we talk about AFib, what are your two key characteristics? Like if you're trying to pick it out on an EKG strip, what are the two key things you want to remember?
No clear P-wave.
That's right, don't have clear P waves. And is it regular or irregular?
Irregular.
Yeah, it's irregular, you don't have clearly defined P waves, okay? So when we talk about AFib, Nicole, what puts some people at risk for developing AFib?
Well, I'm on a brain.
What friend you want? Or do you want to make a new friend?
Haley.
Haley. Okay, what? She might not be your friend after tonight. Just saying. Okay, so Haley, what are some things that make a person predisposed for developing AFib? Obesity? Smoking? How about hypertension? Absolutely. Diabetes, yeah, hypertension, diabetes. Also age, guys, just realize age is one of those gifts that just keep on giving. Okay, so as we get older, we are more likely to develop AFib. Remember, it's the most common dysrhythmia following open heart surgery. So you'll probably take care of some patients that have AFib. And again, also any type of cardiac disease such as congestive heart failure, valve disorders, it puts a person at a higher risk. So remember, in AFib, it's a very chaotic rhythm with no clearly defined P waves. Okay? So Haley, will you please select someone? Yeah, pick her. She's not looking at you.
Amber's not here right now. She will peek it right on over here.
Okay, Amber, here's my question for you. You got this. You got it. Okay? Why do we worry so much about AFib? Like, why don't we want people in AFib?
I don't know, could they die and lose all oxygen to the brain or something like that? I don't know. Like I call up here, I wouldn't believe.
That could potentially happen, yeah. But select somebody, Amber. Select somebody.
Yay!
Why does everybody pick on you? Are you not nice outside?
That's what I'm saying. Yeah, I guess not.
We're just gonna upload the videos today.
Oh, look, Josh is like, I got you, man. I got you. Okay. Why? I mean, really, why do we worry
they have a
about
risk of
AFib?
stroke.
Yeah, why? What's happening?
The heart's not pumping correctly.
What's happening with the heart?
It's like fluttering, kind of like a quivering. Yeah, quivering.
It's quivering. Remember, your atria is just quivering right here. Your ventricles are working, but your atria is not. And so anytime you have a place that the blood just pools, what are you at increased risk for?
Blood clots.
Yeah, blood clots. So that's why we worry so much about AFib, and we want to get them out of AFib if we can. But remember, as soon as the patient comes in and you know they're on AFibs, one of the first things you should be looking at is, okay, are you on some type of a blood thinner besides aspirin? Okay, because let's be real, when you get like to age 50, you're gonna be put on aspirin. Okay, it's again a joy of getting old. But we need something more than aspirin. Okay, just to try and keep their blood thin. So that's what we need to worry about. So our whole goal, remember, is to convert them back to normal sinus rhythm. Okay? So what are some, not first.
No, not
Okay, you all want to go straight to the shocking. What are some things what are some meds that we might potentially give to lower that and try and convert them? DIG, beta blockers, calcium channel blockers, yeah, cardizem's a great one. Okay, so we try and do that IV first, right? If that works, then what are we gonna do? Can we send them home on IV meds? So what will we do? We'll transition them to what? PO meds, okay? We'll transition them. But let's say that doesn't work because Quan doesn't want that to work, okay? Then, what are we gonna do? Cardioversion, okay? So remember, cardioversion is just simply, we are delivering shocks to the heart to try and get it to temporarily pause, and then when it starts back, normal sinus rhythm, okay?
Quick question.
Hopefully.
Okay, say we have somebody in AFib. You do have to get an informed consent for cardioversion, right?
Uh-huh.
So would that be birth verbal, or is that something quick, or how?
So in AFib, your patient is usually, your patient's with it. It's an atrial dysrhythmia, so it doesn't have the ramifications of ventricular dysrhythmia. So your patient's able to sign consents, they're able to interact and talk with you, okay? So they'll be able to definitely sign a consent. But before you do that cardioversion, what test do we wanna do? Why?
Look for clots.
Yeah, remember they're at an increased risk. We want to make sure, because do we want to shock a heart that already has clots in there? Nah, because then what will happen to those clots? Yeah, they'll go out, and so we don't want that to happen. So absolutely, that's cardioversion. So after cardioversion, what's another option we could potentially do?
The radio frequency catheter.
Yeah, the ablation. Okay, so the premise is there's some site in the heart that is causing these irritabilities. Okay, so what they're going to do is they try and determine that site and they try and cauterize it. So essentially, it's the same procedure as a cardiac catheterization. It's just the intervention's different. What they'll do is they'll go in there with this little cauterizer tool, and they will just burn the area that they think is causing those extra irritability that's resulting in the AFib. If they get rid of it, then you know what? The AFib hopefully will go away. So that's another option that we can have, definitely, okay? So those, let's say we do all that and they still are in AFib. What is our, why, I should say, what do we shift to? Are we gonna get them back in normal sinus rhythm? Probably not. So then what is our focus?
Rate control.
Yeah, rate control. We want them to be controlled, not AFib with RVR, okay? Because remember, the higher the rate, the more symptoms the person's gonna have, okay? And then also, if we can't get them out of the AFib, just realize they're gonna be on lifelong blood thinners, okay? Now, there's different kinds, and we have a lot of new ones out that don't require all the monitoring that some of the older classifications did. But that's the primary thing, is we need to make sure that they stay on their blood thinner, communicate it to all of their healthcare providers, especially before any type of interventions, okay, or procedures that they might have. So that's everything that we're gonna do with that one. So now, Quan, will you select someone to tell us a little bit about a flutter?
Ty.
Now, I knew everything about AFib, and you would select me. I don't know nothing about AFib.
Hey, but you know you do. You already know all the interventions because they're the same. So if I was looking on a strip and I'm trying to identify, what are your two main characteristics of a flutter?
You don't have P waves and it's irregular. No, flutter is regular, but you don't have P waves and
You have those flutter
the
waves.
flutter.
It looks pretty.
It's pretty. Remember, I told you this is your pretty atrial dysrhythmia, and a flutter is your ugly one. Okay. So it's still an atrial dysrhythmia. We don't worry about blood clots with this one like we do with the AFib, but our interventions are the same. We want to convert them back to normal sinus rhythm. So what are our interventions that you would anticipate?
Medications.
Absolutely.
Your blood thinners,
Not your blood thinners.
your beta blockers, calcium channel blockers.
Something to try and convert them? Absolutely. Okay? If medications don't work, what type of interventions?
The cardioversion for the ablation, and then just trying to control the heart rate.
Yeah. So it's an atrial dysrhythmia, so we treat it kind of the same as far as the interventions. Okay? That is where we left off last week. So what you got for me?
Well, question, in regards to like the magnesium lab, right?
Mm-hmm.
So on this document here, of course, it's saying 1.6 and 2.0, but in the book, it's giving 1.8, 2.6.
So these change based on, they'll change based on facilities, they'll change based on everything. But for testing purposes, you want to go by the book.
Okay.
Okay?
All right.
That'll just keep it consistent with
Yes, ma'am.
everything.
Thank
And
you.
with the atrial flutter, they can be pretty or the soft tooth, right?
With a flutter is the pretty one. You have these nice, pretty flutter waves.
Procedure.
Okay, or yes, so some people call them sawtooth,
Okay.
but they're pretty. It's a real
Right.
pretty distinctive. And then your AFib, it just looks like chaos. Like you have this QRS and then you just have these little chaos in between.
So do we
Okay.
need to know about the maze procedure?
No, because we really don't do the maze procedure that much anymore. If we do it in conduction with like open heart
So
surgery.
more like the ablation and the.
Yeah, those are your standards, are your ablation and your cardioversion are your standards. Okay. So now let's start on your blocks. pull them up here. Okay.
I was looking at the first six.
No.
No, 'cause I got, it looks, I can't never figure out what page she's talking about.
I found it in the.
Okay, so let's talk about your blocks. You won't really find your blocks in your textbook. There's not a lot of information, so you'll want to use my my PowerPoints for your blocks. Okay, there's just, I don't know why they just skipped blocks for
They think it was
whatever. They
important.
didn't think it was important, I guess, but it is. So let's talk about these blocks. We have different types, and we're going to cover all of them. The first one I like to start with is a first degree block. So here's the thing you have to realize about a first degree block. It's not truly a block. Okay, they group it in, but it's more of a delay. All the impulses get through, they just take a little longer. So I always like to think about a first degree block like that friend. You know, the friend who gets everything, but never when everybody else does. It's always after the fact. And if you're not laughing, it might be you. That's saying. But it's just a delay. That's all it is. Okay? So let's do the 5-step method because I like to be consistent. Okay? So when you are analyzing a strip and you're trying to determine what's going on in a first degree block, your rate usually is going to be between 60 and 100 beats per minute. Your rhythm is going to be regular. Okay. Then you're going to look at your P waves, and what you will notice is you do have a P wave before every QRS, and your P waves are similar in appearance. Then you go to your PR interval. What you're going to notice about your PR interval is that your PR interval is consistently greater than what it should be. So it's going to be greater than 0.20 seconds, so that's greater than 5 small boxes. Okay? And it's consistently going to be that. Then what you're going to look at is you'll look at those QRSs. And what you'll notice about your QRSs, they're within defined limits. So the only thing wrong here, guys, is your PR interval is just longer than what it should be. What that tells you is it's just taking longer for that impulse to get from the atria to the ventricles. Okay? So when we look up here, what is the rate that y'all get? 60. Okay? Is it regular or irregular? This is regular. And now what I want you to do is I want you to go and look at your P's. Do I have a P before every QRS?
Yes.
And are they similar in appearance? Yeah. Well, look at your PR interval. Okay? When you look at this PR interval, remember you measure your PR interval from the beginning of your P to the beginning of your QRS. What you will notice, it should be no more, I tell you, it should be no more than 0.20 seconds. When you look at this, that's like 9 boxes. Okay, it is, it's way too long. And then let's say this one is 9 boxes. Well then I go and I look right here and this is 9, and this is 9, and that's 9, and that's 9. It's consistently longer than what it should be. That is your first degree block. And it's not a true block, it's a delay. All the impulses get through, they're just slow about it. Okay? Here's another great example right here. Okay? And that's why I promote you doing the 5-step method until you get really good at it, because sometimes it might just, this one will get some people. Okay? Because it looks completely normal until you really start looking at it. So what's my rate? Apparently I like 60 because most of mine are 60, but it's 60. Is it regular or irregular? Regular. Remember, you're looking at the spaces between your R to R's, and they should match up. Okay? So now what I want you to look at is look at your P's. Do I have a P before every QRS, and are they similar in appearance? Yeah. Okay? Go to your PR interval. When you measure your PR interval, this one I have it for you. But for example, that's 8 boxes. What does that tell you? It's too long. It's a prolonged. And if I were to compare all my PR intervals, they all would be 8 boxes. The only thing wrong here, guys, is that PR interval is just too long. So now you know it's a block. Okay. When you look at your QRSs are within defined limits. This is your first degree block. Realize a first degree block, most people absolutely no signs or symptoms. And it could be common, this just could be the person's underlying rhythm. So in that instance, we would not be concerned. However, realize that there are some things that can contribute to the development of first degree block. One would be if they have some type of cardiac disease. Or it could be, guys, because of medications. Some medications cause a prolonged PR interval. So now when you're reading your nursing interventions or things to monitor in your drug book, when it says prolonged PR interval, you know what that means. It means it's going to take longer for the electrical impulse to get from the atria to the ventricles. And so now you see why we get a little concerned about, if we have significant prolonged. So if it's medication related, then what we're going to do, or what you would anticipate, is the physician changing out the medication. Either lowering the dose, maybe changing it to something else that doesn't have those side effects, okay? If it's not medication related, we're not going to do anything about it. We just do nothing. We look at it like, oh, it's first degree block. Chart it and move on, okay? Because remember, it's normal for some people. It's just their norm. Okay? Now, let's go to our secondary blocks. Now, these are true blocks, so let's talk a little bit about them. You have second degree type 1. Oftentimes, in clinical practice, it'll be referred to as winky block. Okay. So what's happening here is impulses, they take a little longer to conduct through that AV node until one impulse is completely blocked. And when an impulse is completely blocked, it will, if you look on your EKG, what you will see is a dropped QRS, because it failed to conduct from the atria to the ventricles. Okay? Again, this is usually asymptomatic. The only time it becomes symptomatic is if the frequency of the drop beats, it impacts the overall ventricular rate. Okay. Some causes of a second degree type 1 block. The person could have had a MI. They could have an electrolyte imbalance. Or sometimes these will occur after some type of cardiac surgery. So if you're going to do your 5-step method, the rate is going to vary. I can't give you it's between here and here. It just varies. Kind of depends on the number of beats that are being dropped. Okay. Your rhythm, it's going to be irregular, guys. P waves, you will notice that you do have a P wave before every QRS, but that you don't have a QRS after every P wave. Okay? I'm going to explain that in just one moment. But you will have P waves before every QRS, but there's not a QRS complex after every P wave. So that means I'm going to have some extra P's. And then you look at your PR interval. Remember, in your blocks, your PR interval will tell you so much. When you look at that PR interval, what you notice is it gets gradually longer with each beat until it fails to conduct. And when that happens, you'll see a P, but you will not have a QRS that follows it. And then your QRS complexes, they are within defined limits. Okay? So when we look up here, my overall rate is probably 60. Let's see. 60, okay? So is this regular or irregular? Look, it's irregular, because look at your places between your R's, they don't match up. Okay? So now go and look at your P waves. Do I have a P before every QRS, and then they're similar in appearance? Okay? So there's a P, there's a P, uh-oh. You notice I have extra P right here?
Right. Mm-hmm.
Okay? And then There's a QRS, there's a P, there's a QRS, there's a P, there's a QRS, there's a P. So the first thing you notice is, oh, I have an extra P here. What happened was that atria failed to conduct to the ventricle at this time, right here. And so because it didn't conduct, you don't have a QRS. Because remember, your QRS shows what's going on in the ventricles. So that's your first indicator that this is a second degree type 1. The other thing you look at is let's look at our PRs, okay? When you look at your PR intervals right here, what you notice is that your PR intervals get progressively longer until you drop a beat. And then look at the pattern, guys. It's all about patterns. Look at your PR interval. You see how it gets longer, longer? So I usually refer to a secondary type 1 as your going, going, gone rhythm. Your PR interval gets longer and longer and longer until boom, it drops a beat. So that's when you'll have a P and no QRS, and then the pattern starts over again. Okay? Let's try this one. Okay? My rate, 60. 60, okay. Is this regular or irregular? Irregular. Does everybody see that? Okay. Now, what I want you to do, I want you to go and look at your P's. What do you notice about your P's? Does everybody see the extra one? Okay. So if you're ever in doubt, guys, remember I tell you, always go to your QRS. Remember your P's always going to be in front and your T's always going to be after. So if you get kind of confused, just always go find your QRS. So there's a P, there's a P, there's your P. Uh-oh. Do y'all see it right there? And then there's your P, there's your P, there's your P. So you've identified that I have extra P here. Now go look at your PRs. Look what happens to your PR intervals, okay? From here to this one, till it drops. And then look, your pattern starts over again, okay? It's a pattern, going, going, going. So this is your second degree type 1. Now, when you think about your second degree type 1, typically we don't have to treat this, okay? We could try some atropine to try and improve the AV node conduction, or we might have to put a temporary pacemaker on them, but usually we don't do anything if they're stable, okay? As long as their overall ventricular rate's fine. What's their overall ventricular rate here?
60.
Are you okay with that? I'm okay with that. So your patient probably symptomatic. If my overall ventricular rate was 30, think my patient might be symptomatic? Yeah. So again, I would try and get the heart rate up and figure out what's going on. So when I talk about ventricular rate, remember that's you got your QRSs. Okay? So as long as it doesn't impact the overall ventricular rate, then we consider them stable and we're not going to do anything. As I said, we'll give them atropine to try and increase the conduction through the AV node. We'll give them oxygen if they need it because they don't have enough circulating. And like I said, we can do external pacing like I talked to you about last week. Okay? But that's only if they're symptomatic. Now let's talk about second degree type 2. So what's happening in second degree type 2 is there's a block and it's occurring below the bundle of His. So now y'all know the conduction system, you notice at like the very bottom, that's where this blockage is occurring. So what happens here is the impulses are just randomly blocked, okay? When you're doing the 5-step method on second degree type 2, your rate is going to vary. Okay. Your rhythm, it could be regular or it could be irregular. You will have a P wave before every QRS, but there will not be a QRS after every P wave. Now, your PR interval. Your PR interval could be normal or abnormal, but it's gonna consistently be the same when you have a PR interval to measure. Okay, and I'll show you that in just 1 minute.
Can you repeat the last part about the PR interval? I'm sorry.
And this mic part, can you start back at the P wave?
Okay, you will have a P wave before every QRS, but you will not have a QRS complex after every P wave. And then with your PR interval, it could be normal or abnormal, but it will be constant when the impulses are conducted to the ventricles. And I'll show you what that means, okay? And then when you look at your QRS complexes are within defined limits. Okay? So what I mean by when I talk about your PR interval, it's gonna be the same, be it normal or abnormal. So when I look at this PR interval right here, and let's say it's 4 boxes, okay? When I measure this PR interval, it'll be 4 boxes. Well, I mean, I can't measure it here because I don't have a QRS, right? So I can't measure that. But my next available PR, it's 4 boxes. So it's consistently the same when you have a PR interval, okay? It could be normal or it could be abnormal. So if you were doing your 5-step method on this, what's my rate? 30, okay? See that? So overall rate's 30. Is this regular or irregular? It's irregular. Okay. Now what I want you to look at is look at your P's. Do I have a P before every QRS? Similar in appearance. Okay? There's my QRS, there's my P. There's a P. Uh-oh. What do I have right here? Or what am I missing? Yeah, so it tells you right there. It failed to conduct at that point in time. And then I have one right here. Okay? So now you know that you got some extra P's in here. So then you go to your PR interval. Okay? And what you're looking for is you're looking to see is it consistently the same. So if this is 4 boxes, then this will be 4 boxes, and this will be 4 boxes. And then the last step is your QRS is within defined limits. So I'm telling you, those PR intervals, they're going to help you so much in trying to determine what block is this. Because almost all of them have some type of a pattern. First degree block, remember, it's a delay. So you just have a prolonged PR interval. Second degree type 1, your PR interval gets longer and longer and longer until boom, it drops, and that pattern starts over. In a second degree type 2, when you're looking at that PR interval, what you're going to notice is consistently the same, be it normal or abnormal. So if it's 4 boxes, then each one of these will be 4 boxes. If it's 12 boxes, then each PR will be 12 boxes. Okay? So that PR interval is really going to help you in differentiating your blocks. We do worry, guys, about a second degree type 2. Okay? And the reason we worry about it is because oftentimes it will progress to a third degree block, also known as a complete heart block. Okay? So we do worry about this type of block. So when we think someone has a second degree type 2, you know, we're always going to verify it. We'll do an EKG, make sure that's what's going on. Then we're going to assess our patients because their symptoms depend on what is their overall ventricular rate, because that tells us how many beats they're dropping. So for example, y'all told me this guy's rate was 30. Do you think he's symptomatic with it? Absolutely. Okay. If his rate was 70, do you think he would be symptomatic with it? Not really. Okay. So realize that your symptoms are going to be dependent on what is the overall ventricular rate. Okay. Some things that can cause a second degree type 2, again, the person could have had an MI, they could have some type of cardiac disease. Let's see, myocarditis, that'll cause a second degree type 2. Also ditch toxicity. And so that's what we worry about because this frequently does progress. So when someone is in a second degree type 2, remember our overall goal is we got to increase the overall rate, right? We got to get that ventricular rate up. We get that ventricular rate up, it'll improve their cardiac output. The problem is, remember, one of our gold standards for getting your rate up is atropine. Atropine doesn't work really well on this block because of where the blockage actually is. So remember, it's in the bundle of His. And for whatever reason, atropine doesn't work on that area of the heart. It's not as effective. So yes, we will try it, but it's just not really, we're not gonna see the results that we would like to see. Okay, but we will try that. Usually what we end up having to do, we will have to put them on external pacemaker. So a lot of times in the clinical setting, we refer to it as pacing. We'll just externally pace them. So that's kind of like last week when I talked about how you could put them on the pacemaker. So it's external until we figure out what's going on. If it's because they just have some malfunction, for whatever reason, their nodes are impaired and they need to be fixed, then they're going to have a permanent pacemaker. Okay. If the reason they're in this block is because of medications, let's say vig toxicity, then they would stay on that external pacemaker until it's resolved. Okay. So the permanent solution for someone who has second degree type 2 is a permanent pacemaker. Okay. Because remember, our overall goal is to keep that ventricular rate up so you'll have adequate cardiac output. So oftentimes people that do have a second degree type 2, they will have to have a pacemaker. Now, the last type of block I'm going to talk to you about is something called a third degree block. Or you also hear it referred to as a complete heart block. Okay, so what happens in a third degree block is you have no communication, guys. Your atria is doing its thing and your ventricles are doing its thing, and they are not talking at all. So realize if they're not communicating, there's no relationship. It's kind of like a marriage. The husband and wife, if they don't communicate, it's not that they're not going to be married for long. Okay? So the same thing's going on there. Your atria is doing its thing, the ventricles are doing their thing, and they're not talking. You can't live for very long in third degree heart block. Because think about it. Think about what all we talked about that goes into actually your heart beating. It's not doing it right now. So if you're doing the 5-step method, what you need to realize is that your rhythm, it could look regular or irregular. Say it just looks regular or irregular. Because the atria is doing its thing and the ventricles are doing their thing. They're not talking to each other. So then therefore your rates are going to be different. You'll have an atrial rate, you'll have a ventricular rate. You'll have P waves, but they don't mean anything. They're just taking up space. Okay. You'll have Curious complexes, but they're not where they should be. They're either going to be less than what they should be, or they're going to be greater than what they should be. They don't look quite right. So the way I always like to tell people, when you're trying to figure out what's going on, let me give you an example, okay? If your P and Q don't agree, then you have third degree, okay? So that's always a great way to remember. If your P and Q don't agree, then you have third degree, okay? Everything is a little off in third degree. And that's what you have to realize. So when you look up here, you'll see you have components of everything, but it's not where it should be. Like, I have P waves. I kind of have P waves all over the place, but I don't have QRSs after them. Look at your PR interval. Look at all the different links. What strip have I taught you that has all these different, that doesn't? See, none of it's going. It's just stuff up there. So your atria is producing electrical activity. That's why you see things up there that look atrial in nature. And your ventricles are doing its thing, but they're not in coordination. So I always tell people, when you're looking at a strip and you can't figure out what it is, there's no rhyme or reason or pattern, that's third degree. Okay? You need to worry about third degree. If you hook a patient up to a monitor and something like this comes up and you can't figure out what it is, we got a problem. They won't live very long in third degree, okay? because we have to have communication in order to have cardiac output. If we don't communicate, we're not gonna have cardiac output, okay? So the atria and the ventricles, they're beating independently. So you're gonna start seeing signs of decreased cardiac output. They're gonna have severe fatigue, dyspnea, dizziness, okay? They're gonna have a change in mental status. They'll become hypotensive. They're gonna develop chest pain. So this is what all you will start seeing, because they're not communicating right here, okay? So of course, we always wanna verify with an EKG. So we'll verify it till telemetry ever calls and says, hey, patient's in 3rd degree. They're in 3rd degree, probably it'll hit the little buzzard and it'll ring at your nurse's station. But you go and you verify, and this is what you're gonna see. Now, Stokes-Adams syndrome, I was feeling a little left out because Dr. Whitaker loves big words and she loves to use them, and so I thought I guess step up my game and throw some big words in there. So all Stokes-Adams syndrome means is they have period of, they go in and out of consciousness. But isn't that so cool? So now I challenge you to use it this week, okay?
Just don't test us on it.
Come on now. I won't test you on Stokes-Adams syndrome, okay? I won't test you on it. But that's essentially what's happening. They're just going in and out of consciousness, and it's because of the lack of oxygen. They get extremely confused because, again, oxygen is not getting to the brain. Okay? And I say it will lead to cardiac arrest if you don't do something. So some things that can cause a 3rd degree block. Again, the person could have had an MI. Severe electrolyte imbalances, guys. So potassium, magnesium can cause this. And again, dig toxicity can cause a 3rd degree block. So what we need to realize in a 3rd degree block, if it is not medically induced, the person has to get a permanent pacemaker. Has to.
So that's what you mean by, okay, we see the question like this on the test and we have to intervene. We see our interventions. We need to know that they ought to be a permanent.
If you see a 3rd degree block, then yeah, if it's not medically induced, I mean, you need a little bit of history, like what are these meds, or what would you do? But a 3rd degree block, you can't stay in it for very long, so you're gonna have to have some type of pacemaker. Okay. So, those are your blocks, and what I always like to tell people, this chart is gonna help you. You always wanna go to your PR interval with your blocks, okay? Because think about it, 1st degree, it's just longer than what it should be. 2nd degree type 1, your PR interval gets longer and longer and longer until it drops and the pattern starts over again. In a 2nd degree type 2, your PR interval is consistently the same. Now it could be normal or abnormal, but if that first PR interval you get is, let's say it's 0.20, then every other PR interval in that strip should be 0.20. Okay? And then 3rd degree, there's no relationship, so you can't really measure a PR. Okay?
Question about the 2nd degree,
Okay, which one, type 1 or type 2?
the type 2.
Okay, what you got for me?
Actually, the rhythm strip.
Uh-huh.
So, I had a patient last week that had the inverted QRS. So, is that considered inverted, or?
Was it, so it just looked like,
So it
it's just a
doesn't-
different strip, it's just a different, it looked like this?
Yes.
Okay, it's just a different, they just looked at a different lead.
Okay.
It doesn't necessarily mean any, it's just negatively deflected versus positively deflected. Okay?
That makes sense.
Question, also, would that be a bundle branch block there?
Potentially. Because it occurs below the bundle of His. So definitely could be. Okay? So guys, now we are gonna move on to, let's see, your ventricular dysrhythmias. And then I'll give you a break, okay? Oh, we got like 3 more, then I'll give you a break. Sound good? Okay.
I've been up ever since that one lecture.
Oh, you're making sure I'm not calling you anymore, huh? Is that what that? I got you. But I mean, I get it though. It is long. But we just got so many clinical obligations that we can only really afford to do lecture 1 day a week. Okay, we're gonna talk about our ventricular dysrhythmias, okay? So PVCs, VTAC, and VFib. Now these, asystole and artifacts, I introduced you to those. They're not necessarily ventricular dysrhythmias, it's just a good place to introduce them, okay? So, when we talk about ventricular dysrhythmias, the first thing we're gonna talk about is something we call a premature ventricular complex, okay? So what you need to realize is that a PVC is just an extraventricular contraction that is usually caused by electrical irritability in the ventricle. So your PVC, it's going to consist of a very abnormally wide and bizarre QRS complex, and it occurs earlier than what it should be. So if you we're doing the 5-step method, your rate is going to follow the underlying rhythm. Okay. Your rhythm, it's irregular because of the PVC. The PVC will not be preceded by a P wave, so you're not going to be able to measure a PR interval. And then when you look at your QRS complexes, what you will see is that they are wide and bizarre. It's larger than what it should be. Now, in your book, you have a great, I'll tell you what page it is. It has a really good figure that talks to you or shows you. Look on page 657, figure 3112. It's in the 10th edition. And you have it in the 9th edition, but that page is wrong. But it gives you, it talks about PVCs and it gives you 2 great examples, A and B. Okay? So we were doing our 5-step method, so let me skip through here and show you. Okay? PVCs are easy to find. They don't belong, guys. So that's what you have to realize, that PVC occurs earlier than what it should and it doesn't belong. So when you look on your page 657 on A, what you see is there are 2 PVCs, because what happens at that PVC, it is a wide and bizarre QRS that doesn't look like the rest of them. So when you do that, you see there's 2 that don't belong. Yeah, right there. And then over here, look what doesn't belong. Okay? So they're easy, they're easy to pick out. You see, they don't belong. What page is it? 683 in the 9th edition, guys. Okay? But when you look, that's kind of what you see on those is you have these wide and bizarre QRS complexes that don't match anything else. So the neat thing about PVCs is oftentimes they come in pattern. They could come one, like this is just one PVC, but sometimes they come in patterns. So some of the patterns that you will see, you can have pairs, or sometimes they're called couplets. That's 2 PVCs in a row. You can have runs or bursts. So if you have 3 or more PVCs in a row, we typically call that non-sustained VTAC. Okay? You can have bigymny. Bigymny is every other one. Tri is every 3rd, and quad is every 4th. In addition to coming in patterns, you can have something that's unifocal or uniform or multifocal. So essentially what unifocal means is it's coming from the same side of irritability, and so therefore the PVCs are going to look the same. So when you look right here, you should see 2 PVCs. Does everybody see 2 PVCs? This one right here and this one right here. Do you see how it's wide and bizarre and it doesn't look like the rest of them? Okay? So that's how you pick out PVCs. It doesn't belong. Kind of like those Where Waldos that you used to have and you had to find what didn't. So they're easy to pick out. Now what you do is you look at it. Are these the same PVCs or are they different? And what you'll find by looking at those two look the same. So we would call that unifocal PVCs or uniform PVCs. All that means is they're coming from the same side of irritability within the ventricles. So they're going to look the same. Okay. So here's an example of multifocal PVCs. So when you look right here, how many PVCs do you see?
3.
Does everybody see 3? Okay, 1, 2, and 3. Do you see how these two look similar, but this one looks different? What that tells you is this is coming from a different site than those. And so it's multifocal. It's meaning there's different sites of irritability within that ventricles that's causing that. Okay? So let me give you some more examples. Oh, I'll ask you. How many PVCs do you see right here?
One.
Is it unifocal or multifocal? How do you know that?
It's one.
What are you comparing it to?
Just that.
You can't compare it to itself. So this one, that was a trick. This one right here is just a PVC. That's all you can tell me. That's all. You got to have more than one to compare and say it's unifocal or multifocal. So you're just telling me there's the PVC. Here's another great example. Look right here. This is called bi. Bi-Gemini is every other beat is a PVC. Do you see how every other one is a PVC? Now, tell me, is this unifocal or multifocal?
Uniform.
Yeah, unifocal. Okay, now look at this one. This is multifocal. How many PVCs do you see? Okay. Do you see why it's multifocal? You see why your PVCs look different? Absolutely. Okay. This is called tri-Gemini. Tri is every third is a PVC. So as you can see, 1, 2. There's your every third. Is this unifocal or multifocal? Yeah. And here's quad. Quad is every 4th beat. So I kind of have them circled right here. Okay? Unifocal, multifocal. Yeah. So here's the thing. PVCs are common, guys. They're common. They increase with age. The older we get, it's a gift that just keeps on giving. The more likely we are to develop PVCs. Okay? We become concerned when someone's having excessive PVCs. So if someone has 6 or more PVCs in a minute, that's cause for concern. That's like, okay, we got to figure out what's going on here. And the reason that is because oftentimes PVCs can be like a watch rhythm. Because if someone's having frequent PVCs, it can indicate that they're going to go into VTAC or VFib, which those are really bad dysrhythmias we don't want our patient to go into. So if someone's having, again, more than 6 in a minute, you better be doing something. Some other things that can cause PVCs that I like to talk about. One is stress. So you probably have had PVCs throughout nursing school because anytime you're stressed, you're more prone to develop PVCs. Okay. A lot of times, when people feel that they're having PVCs, if it's just occasional ones, typically asymptomatic, they don't really notice. If someone's going to complain about anything, typically they'll complain about like a chest pain, or maybe they feel like their heart's skipping a beat. Okay, that's the biggest complaints that they will have. So stress is one, guys. Caffeine is another one. Okay, my people that ingest large amounts of caffeine, you are more prone to develop PVCs. So we talk about let's maybe cut the caffeine down a little bit.
What about the cocaine users?
Well, I mean, it's not a lot. Just a little bit. Okay. Definitely, cocaine's not good for you. I'm never do cocaine. It is horrible for you. I forgot y'all record me. Okay, that's my official stance on it. Never ever.
What's some more address about cocaine? We have it too.
Moderation is key.
Yeah, moderation. Yeah. Smoking is another one, guys. People that smoke heavily, they're more likely to develop PVCs. Okay. Also, it's more common in your postmenopausal women. Okay. And so those are just kind of things that you need to be aware of. We also look at electrolytes. If someone's having frequent PVCs, we want to look at what's their potassium, what's their magnesium. Because what we find is oftentimes it's low. So once we figure out what's causing these PVCs, then we got to treat it. So if it's because they have a low magnesium or a low potassium, we're going to give them supplemental potassium and magnesium. If they're having frequent PVCs, then what you can anticipate is we're going to give them lidocaine, or we might even use a medication called amiodarone. So I don't know how much you know about lidocaine, but the whole premise of lidocaine is it is going to help relax, try and help numb it out. Because think about it, we give it before we start IVs, right? You're supposed to offer lidocaine before you start an IV to help lessen the person's anxiety. Okay, that is the official policy. Is what you're supposed to offer. And what it does is it numbs the area, right? So here's the thing with that. If it does the same thing in the heart, so that side of irritability that keeps throwing off all those extra electrical impulses, it's going to numb it out. Okay, that's Daniel's Drug Book 101. That's what's going to happen. So that's what we're doing it. Okay, we're trying to chill it out a little bit so we don't have all those extra impulses flying around, causing it. So lidocaine, in this situation, of course, we're going to give it IV. Okay. So the other type of ventricular dysrhythmia I would like to talk about, we're going to talk about VTAC. Okay, so let's talk about it. If you're going to do the 5-step analysis on VTAC, your rate, typically it's between 100 to 250 beats per minute. It's really fast, guys, really, really fast. So I can get you a picture of it. Okay? Your rhythm is usually regular. Underline usually. Okay? Underline usually. And the reason I say that, if it's really regular, then all of a sudden it starts becoming irregular, what that tells you is that's like, uh-oh, be careful, it's going to convert to something. And usually it's like a V-fib. Okay? What you will notice about your P waves, typically they're absent. You don't really have P waves when you're talking about VTAC. Okay? If they're there, they don't have any relationship. So I can't measure a PR interval. Then when you look at your QRS complexes, what you notice, they're wide and bizarre. Okay? They're greater than what they should be. So they're greater than 0.12 seconds. The reason we worry about VTAC is it is, as I put here, it's usually the initial rhythm and cardiac arrest. Most people go into VTAC first. Okay? Some things that can cause VTAC. The person could have ischemic heart disease. Okay? Again, low potassium, low magnesium levels, or they could just have heart failure. So VTAC exists when you have 3 or more PVCs in a row and you have a rate greater than 100 beats per minute. Okay. You can have a short burst. Short burst means it lasts less than 30 seconds. Remember, we call that non-sustained VTAC. But if the VTAC, if it persists longer than 30 seconds, then we call it a sustained VTAC. Okay. Here's another great example. This is VTAC. This is one of those, when you see it on the monitor, you better be like, uh-oh, gotta do something. Okay? Because you do, and you have to do it fairly quickly. The first thing we're going to do, guys, we are going to make sure and get an EKG, and that is what it is. Then assess your ABCs. What's your level of consciousness? Because it kind of determines what we're going to do. If the person is stable and they have a pulse, then we're going to do cardioversion. Typically, it's synchronized cardioversion. I'm sorry, if it's unstable, VTAC with a pulse. Cardioversion. Medications you can anticipate giving here, lidocaine, guys.
A lot of cocaine.
That's right, lidocaine. Look, don't try and get me in trouble. Get you. If it's because of an electrolyte imbalance, then let's give them replacement, obviously. We might even give some beta blockers to try and slow this down, because this rate is so fast. We just got to try and slow it down.
So we would try those first, you're saying? If it,
It kind of depends. If they're stable, then what you're going to do is we'll try medications. But if they become unstable, then we're going to do the cardioversion. And then if they don't have a pulse, okay? So if it's called pulseless VTAC, what you're going to do is you're going to defibrillate, okay? So those are interventions, so it's kind of important that you know what type of VTAC is it. Okay. So realize, and I strongly encourage you, most people in this situation need to be ACLS certified. Okay, it's an additional certification you get beyond what you've learned in nursing school. It allows you to push certain emergency drugs, to perform certain emergency procedures that you would need to in this situation, okay? But typically when this happens, you're going to call a code, or you'll call an RRT, and they will be there and they will help you because you want people to help you, okay? You'll have respiratory there, you'll have physicians there, you'll have people from the unit there, so that they can all come in and they can help you. But this is VTAC, so you have to be able to recognize it and kind of figure out, what do I need to do for it, okay? So let's go on to our next pretty. This is VFib, okay? So here's the problem with VFib. You have lots of impulses that are firing in a totally disorganized manner, guys. So what happens is the ventricles, they're not able to contract. So if they're not able to contract, then you know what? They're not able to produce cardiac output. So the ventricles are just quivering there. They're consuming lots of energy and lots of oxygen, but they're not doing anything productive because they're not able to squeeze to let the blood go out to the body. Okay? Oftentimes you will see VFib in patients who have CAD. Okay, it's very prominent in that population. Also people who are on any type of anti-dysrhythmic therapy.
You said CAD?
CAD. You'll see this in a person in a trauma situation, like you have massive hemorrhaging. But guys, you can also see this in severe electrolyte imbalances, potassium, low magnesium. Okay, you can see this after an MI also. So if I was doing my 5-step analysis on this rate, you can't determine a rate looking at these, can you? No. Rhythm, all you can tell me is that it's irregular. Okay? You can't determine a P wave or a PR interval, and you can't even really determine a QRS complex. You just have chaos occurring in the ventricles. That's what's going on here. And the thing is this is fatal unless you terminate it within 3 to 5 minutes. That's all you have. Okay? So when this happens, it's really, really scary, and will always be really scary. There's never a time, even now, that I go into this situation and I'm not like nervous. You automatically do. Because what's going to happen, you walk in and you recognize this is what's going on, you're going to be looking for the nurse, and then you look down at your name badge and are like, it's me, I'm supposed to know what to do, okay? So I know Dr. Radney, she likes to talk about her O moment, like when you first start an IV and you're like, yeah, I got it. You can have an O moment here. It's an oh crap moment. It's like, oh crap, What do I gotta do? So you only get a few seconds to panic, and then you gotta get it together because you only got 3 to 5 minutes to get them back. Because if you wait after that, the person that comes back will not be the person that went down. Because remember, tissues are dying after that point. Okay? So that's what you have to realize. What happens is when VFib occurs, typically the patient will become very faint. They're going to lose consciousness. They will stop breathing, and they will no longer have a pulse. Okay? So what we have to do is we have to immediately defibrillate them. So just remember, you defib the VFib. Always, always. Because if you don't, what's going to happen is they're going to end up in a cardiac standstill. And that equals death, guys. So when you recognize this, just realize, get the pads on them and start defibrillating them. Okay? Again, the medications we're going to give, we'll give lidocaine, but our priority, our pressing thing is we got to defibrillate. We got to get some type of organization going back. We got to get the ventricle contracting like it should again, so it can perfuse out to the body. Because if we don't have perfusion, we don't have anything. So that's your whole goal. Now, the next things that I'm going to talk to you about is not, I should say, it's not a specific dysrhythmia. It's what we call a clinical situation. Okay? So PEA stands for pulseless electrical activity. What this means is, for whatever reason, there's organized electrical activity that you can see on the cardiac monitor. Okay? So you walk in the room, you look on the monitor, and the monitor looks like normal sinus rhythm. Okay? That's what it looks like. But then when I come over here and I'm looking at Jay, looking. Psh, you good, Jay? You good?
Not.
No, he ain't breathing either. He has no pulse, and he's not breathing. But he's a normal sinus rhythm. No, that's just a situation. What are you going to trust, that machine or your eyes? Your eyes and your ears?
Eyes and ears.
You better, because sometimes machines are wrong, guys. And that's what you have to understand. So if you walk into that room, you're assessing your patient, and there's no breathing going on, and there's no heart rate, you know what? You consider them dead and you start working on them. Okay? I don't care what your monitor says, because they are wrong sometimes. And so that's why assessment is key. You've got to be able to assess your patient. Yeah, just having a heart monitor isn't really going to do too much if it says one thing and your patient is not breathing. So here's the problem with PEAs. There's lots of things that can cause it. Like, look right here. Here's your list. So when you think about PEAs, realize we only have like 3 to 5 minutes to figure out what it is and to fix it. We got to restore perfusion. And most of the time in PEA, we don't necessarily know how long they've been down. Okay? So this is a long, long list of things to go over to try and figure out what's going on. So unfortunately, a lot of people that suffer from this, they don't survive it. Actually, most will not. Because look at all we got to figure out what's going on. Okay? So just realize that equipment's sometimes wrong, guys. But your eyes and your ears are not going to let you down. They really aren't. But this is what a PEA essentially is. It's when your patient is unresponsive, they're not breathing, and they have no pulse. Okay? So of course, you're going to start CPR. Okay? You're going to try and figure out what's causing it and fix it. But again, this list is so long for you to try and go through. So that's why most people don't survive. Another thing that I always like to talk about is asystole. You better not get this one wrong on the test. You just better not. If you get this one wrong, I'm gonna be talking to you.
Amber?
The following
Don't play with me. Okay.
I love it, Jay. You just be calling folks out. Okay.
I got you tomorrow.
Okay, so here's the thing. If you're doing your 5-step analysis on asystole, because I've done every other single one, your rate, you're not going to Your rhythm, you're not gonna have one. You won't have a P wave, you won't be able to measure a PR interval, and you will not have QRS complexes. Okay? This is a systole. Please do not, this is 2 points, guys, don't get it wrong.
That's 2 points.
Okay? Even if it looks like this. This is a systole. It's not a this is not a PVC. Okay? It's not a PVC. It's a systole. Okay, so please remember, when you see this, when you see a systole, you have to start CPR. Why would I not defibrillate this? It's not shock, there's nothing there. I gotta have something to work with. Okay? And a systole, there's nothing there to work with. So I start CPR, then if I get something that's shockable, then I'll shock them, but I gotta get something first. Okay? It's like you trying to go to the bank and get money out and ain't nothing there. You gotta put something in. So you gotta get something first. Okay? So I say, how do you recognize it? Well, realize it's a total absence of ventricular electrical activity. So you won't have anything. Now, oftentimes, I know in television, the way they market it is they say it's just, they'll show just a flat line, and it's not, no squiggles or anything. It takes it a really long time to do that. So typically, you always will have some type of movement, but it's not significant movement. It doesn't mean anything. Okay? So in addition to, I'll give you an example. Here's an example of a systole. So this right here is Quan's favorite. This person had some cardioversion. Okay? So this is when the physician delivered the shock. So you see shock, a systole, boom, come back in. Okay? We want it to do it that time. Okay? So the other thing I always like to talk about is artifacts. You're going to encounter a lot of artifact, guys. So artifact is things that look, or they should say, they mimic dysrhythmias, but they're not truly cardiac in nature. Okay? So some examples, and this just, again, hones in on why it's so important to assess your patient. Okay? Here you go. This one right here is loose electrodes. Okay? So things that can cause this artifact, you have muscle tremors, you have loose electrodes, it could be patient movement. So all these things can mimic dysrhythmias, but they're truly not cardiac in nature. Okay, so that's why when they hit the buzzer and they call and they say, hey, 753 is in, VTAC or whatever. Run down there and assess them first. What's going on? Because sometimes it's just not, like I've done that, and I ran in the room and the patient was brushing his teeth with an electric toothbrush. And I thought, you made me run all the way down here. I'm glad you're okay, but now I'm sweaty. Okay? So loose electrodes are one. Or another one, guys, muscle tremors. Especially some of your older patients, your patients that have Parkinson's or some other type of muscular type situation there. Okay? So again, it's just paramount that you make sure and assess your patient first. Okay? So you are going to take, let's see, come back at 2, okay? That'll give you time to go hit up the new vending machines downstairs because they're pretty nice, okay? And we will start on interventions is what we're going to do, okay?